Hi guys, good evening, good evening, good evening. Can you all see me? Can you all hear me? Second. Alright guys, can you all see me? Can you all hear me? Quick feedback. Alright, so today is our BLS Pro day and we'll be discussing two sets of MCQs. So I've clubbed together. Usually I thought I'll do a limited number of MCQs. So today we will be doing MCQs on breast. I'll try to give you some tricky questions. I'll try to give you an objective that how you can actually solve those questions. Okay, chalo. So let's see. We'll start with the first question and then we'll move forward. Now, the question number one that I have right on your screen, that I have a patient. I have a patient who underwent mastectomy. Okay, for a malignant breast lump. Okay, with the axillary lymph node dissection. Post-operative period, the drain was removed. Okay, she presents with swelling in the axilla. Okay, extending into the mastectomy region. Okay, the swelling is soft and fluctuant. What is the next step in the management? Okay, now I have got few. Okay, one of you saying option B. Okay, any more takers? Now, first of all, what is the diagnosis of this case, right? So this, when you say soft and fluctuant, that means there's fluid-filled cavity, and a fluid-filled cavity will be seen in seroma formation. So this is post-mastectomy seroma. It is your post-mastectomy. The diagnosis here is post-mastectomy seroma formation, right? Now, how do I got to an objective that it is a seroma? Obviously, it is soft and fluctuant. Seroma is nothing but inflammatory fluid collection, right? So it is basically the fluid collection in terms of inflammatory response, right? Now, usually remember in terms of mastectomy, we have post-mastectomy complication or post-MRM complication that we call about. In post-MRM complications, we're going to talk about the post-MRM complication. In the post-MRM complication, we have the early post-operative and a late post-operative complication. Correct. So we have the early post-operative complication, then we have the late post-operative complication. Now the mnemonic to remember, the early post-operative complication is what we call it as swab. The mnemonic to remember this is what we call it as swab. S stands for seroma formation. Remember, seroma happens to be the most common post-operative complication. W stands for winging of scapula. It stands for winging of scapula. Now, everybody knows the winging of scapula is because of damage to the long thoracic nerve. It is because of damage to the long thoracic nerve. A stands for arm edema. That is your upper limb edema. Whichever side the MRM is done, same sided arm edema will be noticed, right? The same sided arm edema will be noticed, right? Now, when I say, sorry, the same sided arm edema will be noticed. That means it is ipsilateral lymph edema. Now, remember the most common cause for secondary lymph edema of upper limb, the answer is going to be post MRM status, right? So post modified radical mastectomy, the upper limb edema occurs due to this context. So the most common cause of secondary, see, overall most common cause for secondary lymph edema is filariasis. But when you talk about with respect to your upper limb, it is going to be post MRM status. The last one is going to be B. B stands for blackening. Blackening indicates flap necrosis. It indicates flap necrosis. or the flap gangrene. It indicates the flap necrosis or the flap gangrene, right? So this is your early post-operative complication. Seroma is nothing but inflammatory fluid collection. है ना? Late complication, on the other hand, in the late complication, you have something called as the Stewart-Travis syndrome. Late complication is what we call it as a Stewart-Travis syndrome. Remember, in a Stewart-Travis syndrome, a patient would have undergone a modified radical mastectomy. It takes around 10 to 15 years, right? Or I can say 5 to 10 years at minimum. It takes minimum of 5 to 10 years. So after 10 years of modified radical mastectomy, patient will develop a ipsilateral, same-sided lymphedema. It will have same-sided lymphedema with bluish discoloration of the arm. With bluish discoloration of arm, and this is what we call it as the lymphangiosarcoma. This is what we call it as the lymphangiosarcoma of the upper limb. This is what we call it as the lymphangiosarcoma of the upper limb, right? So this is going to be a Stewart-Travis syndrome. We already discussed it. The management of Stewart-Travis syndrome is 4-quarter amputation. Again, it is associated with very poor prognosis. Seroma is the overall most common immediate post-operative complication. So here they've asked you the same context here. Now look at the question. It says post-mastectomy, swelling in the axilla that extends into your mastectomy site. It is soft and fluctuant and it is fluid-filled cavity. And the management for seroma, it is to drain the seroma and put compressive bandage or the compressive dressing, right? So management of seroma is being asked. So currently, if I say how do you manage seroma, it is going to be USG guided aspiration. It is USG guided aspiration with or followed by pressure dressing. It is followed by pressure dressing, right? So when you look at the whole context, now it is very clear. I would like to aspirate the swelling. Yes, only doing ultrasound. I don't need a radiograph, or I can say a radiologist help to diagnose this condition. Clinically, you can very well diagnose it. Reassurance won't help it because collection of seroma will cause separation of the flap, wound dehiscence, resulting flap necrosis. All there are a common complication. You don't need to reinsert the Romovac drain. You just aspirate it, exert the compressive pressure. It should take care. If it persists, then you can think about it. Otherwise, it's only USG guide aspiration. So here the answer is A for Ahmedabad. Okay? Answer is A for Ahmedabad. Clear? So this is how you'll approach your question about post mastectomy state. Right? Now, going on to question number 2. In a question number 2, I have a middle-aged woman presents with large multilobulated breast mass, family history of breast cancer as well as prostate cancer is present. What is the next step in the management? Now, when I say the family history is present, so this is an HBOC syndrome. Now, in an HBOC syndrome, it is hereditary breast ovarian cancer syndrome, is what we say. Right? Normally, we should get for an HBOC syndrome, you should look for genetic testing. In a genetic testing, you will see the status of your BRCA mutation, that is 1 or 2. If it is positive, then you would offer for risk reduction surgery or strategy, right? That's the objective of having a HBOC syndrome if it is asymptomatic. Okay? In an asymptomatic patient, if there is incidentally found, let's say you're screening somebody and you got a BRCA1 gene or BRCA1 or 2 positive, you will go for risk reduction. Here you can see there is a nice multilobulated breast mass, a large multilobulated breast mass in a middle-aged female. Now the problem here is, see, at this age group and this presentation, it looks like phylloids tumor. It looks like the phylloids tumor. Now, why am I saying it is a phylloids tumor or looking like phylloids tumor? Number one, it will present to you as a huge lump in breast, right? So points in favor, they're usually unilateral. It will present to you as a huge lump in breast. Now, this huge lump in breast will also have rapidly increasing in size. This will be rapidly increasing in size. This would be rapidly increasing in size. It's unilateral. It's a huge lump in breast, rapidly increasing in size. It has got multinodular surface, which is called as the bossulated surface. It has got the bossulated surface. It will have thinned out, stretched skin. It is also associated with pressure necrosis. Also associated with pressure necrosis. Now, on a phylloid tumor, let's say when you generally deal with phylloid tumor, in phylloid tumor, the investigation of choice is going to be a true cut biopsy. It is going to be a true cut biopsy. And in true cut biopsy, you will see presence of leaf-like arrangement. There is leaf-like arrangement. There is leaf-like arrangement of tumor cell. Hence the name, it is called as phylloid tumor. Now, as we all know, the bit of bossulated surface is, this is a surface which is going to be smooth. This is a surface which is called as nodular. But if you have a multinodular surface, you have a surface where you have nodules at multiple sites, this is what you call it as bossulated surface. This is what you call it as the bossulated surface. Okay. Now, when I say in terms of phylloid tumor, remember 95% of them are benign and 5% of them stand as malignant. But how do you know? We have, on the basis of histopathology, we have the HP findings. We will count the number of mitosis for 10 high power field. I will count the number of mitosis per 10 high power field to distinguish whether you are looking at benign, whether it is borderline, whether it is malignant. If the total number of mitosis count that comes out is less than or equal to 4, it is benign. 5 to 9, it is borderline. More than or equal to 10, it is malignant. Now, for benign and borderline, the management is going to be wide local excision. It is going to be wide local excision with 10 millimeters, that is 1 centimeter margin. But if it is a malignant phylloid tumor, then we would go ahead with simple mastectomy. Because usually lymph nodes are spared in phylloid tumor, you don't need to go and do a lymph node dissection. Now, that's the baseline data. Now, coming back to your HBOC syndrome, in an HBOC syndrome, the risk reduction strategy that I can offer for the patient is going to be a bilateral prophylactic mastectomy. The risk reduction strategy that I can offer is bilateral prophylactic mastectomy. If the ovaries are also involved, that is if BRCA gene is positive, then I can do a bilateral prophylactic salpingo-oophorectomy. Bilateral prophylactic salpingo-oophorectomy can be performed. Okay. Now, if you look at the whole question, now this is a very beautiful and a tricky question, because when you look at phylloids alone, if you have to ask me about this, I would look on a histopathology diagnosis. If it is benign borderline, then the answer will become wide local excision. Wide local excision will become answer if it is benign or borderline, if it's a borderline phylloid tumor. Simple mastectomy if it is going to be your malignant phylloid tumor. MRM is done only for proven breast cancers. It is only for proven breast cancer. Sentinel lymph node biopsy is also done when there is an histopathology proven breast cancer. Okay, so I've given you all the objectives and the firepower to answer this question. Now look at the question very carefully. It is a middle-aged female with a large multilobulated breast mass. She has a family history of breast and prostate cancer. What is the next step? It does not tell them that is this lump or this swelling malignant. So when there is no evidence or any mention of malignancy, I cannot go with option C or option D. Right? Now, the option you have to see is simple or wide local excision. Again, they have not told you any HP findings, but they're giving you a clue. There is a family history of breast cancer. In a family history of breast cancer, in a risk reduction, I will do a prophylactic mastectomy, which is a form of simple mastectomy. So here, when you look at it, they did not tell you bilateral prophylactic. They just gave you the word simple mastectomy. So hence, the answer will become A for Ahmedabad. Okay. So answer here is going to be simple mastectomy, which is A for Ahmedabad. Is that clear, guys? ठीक है आई बात समझ में the question looks very simple but when you understand the true nature of the question this is how it is going to fall into your exam as well. Very important way to analyze it. ठीक है going into the question number 3. The third question that I have a young woman presented with palpable breast lump. Ultrasound shows a well circumscribed and this is your pickup point, an echoic lesion consisting of a simple breast cyst. What is the next step in the management? Remember, when you talk about an anechoic lesion, which is simple breast cyst, it is going to be an absolutely benign condition. So there's no need for FNSE or excision. Observation, but should do biopsy again if it's a proven, if it is anechoic, uniform shaped, you don't need to do anything. Just observation is what is required in this case. Now, when you look at this, so this is how the breast ultrasound would look like. So I've given you the interpretation for breast ultrasound. When you look at the breast ultrasound, you have the breast cyst, you have the fibroadenoma, you have the cancer and the glandular tissue. How do you see? Number one, if the borders are uniform, okay, so it is anechoic, oval or round shaped. If there is a well circumscribed margin, there's a horizontal orientation, there's a posterior enhancement, and no calcification. If there's no calcification, it is going to be a simple cyst. You don't need to do anything, only observation. If it is hypoechoic, most commonly it is going to be oval to round. It can be lobulated as well. If it is well circumscribed, again in the same orientation, may have a gross calcification. It is usually seen in fibroadenoma. Irregular margins, hypoechoic with irregular margins is malignancy. Hyperechoic with locally prominent glandular tissue, it's just a glandular tissue, or it could be an inflammatory proliferation also. Okay? So the word that you have to pick is anechoic. If it is anechoic, it is cyst. If it is hypoechoic, it is going to be fibroadenoma or malignancy. Difference is fibroadenoma will have uniform. This is going to have irregular margins. Glandular will be hyperechoic. Okay? So answer here, it is only going to be observation. Moving on to the next question. What is true about Zuska's disease? Now, Zuska's disease is an example of periductal mastitis. So this is what we call it as a recurrent periductal mastitis. It's a recurrent periductal mastitis. The usual age of presentation for this is between 30 to 40 years. Smoking is considered to be a questionable risk factor for your Zuska's disease, but yes, it is considered. If I say what is the underlying pathophysiology or the cause, it is going to be the squamous metaplasia inside the ductal cells. So when you look at the whole component, it said this happens to be the terminal duct, this happens to be your ampulla, and this happens to be your major lactociferous duct. Now you will see that there is epithelial tissue which is present here. There is this epithelial tissue which is present here. Now, the squamous hyperplasia or the squamous debris that is present is going to block this component. If it gets blocked, the secretions are going to pool, and this pooling of secretion will cause recurrent infections. It is going to be recurrent infections. So hence it will result in recurrent periductal mastitis. So it is because of, when you say there is a squamous proliferation, it occurs because of the squamous proliferation. One second, guys. Right? It occurs because of the squamous metaplasia. It occurs because of squamous metaplasia in lacticiferous, right? Another condition where you have recurrent periductal mastitis. Another condition where you have recurrent periductal mastitis in age above 40 years. In age above 40 years, but not associated with smoking as such. Age above 40 years, if you have recurrent periductal mastitis, this is seen in a condition called as duct ectasia. In duct ectasia, you will see there is irregular multiple dilated ducts. The presence of multiple irregular dilated ducts. It is multiple irregular dilated ducts, that is duct ectasia. So under the age of 40 years, it is Zuska's disease. Over it is duct ectasia. Here you have irregular dilated ducts. Here the duct's architecture is normal. Duct look up, the lacticiferous duct appears normal. The lacticiferous duct appears to be normal. The lacticiferous duct appears to be normal. So that is in the context of Zuska's disease, right? So is it a recurrent retroareolar abscess? It is correct. Cord-like swelling which is present on the breast is usually seen in Mondor's disease. So when I say Mondor's disease is non-migratory. It is non-migratory, superficial. It is superficial thrombophlebitis. It is non-migratory superficial thrombophlebitis. The most common vein to be involved, it is going to be the lateral thoracic vein. It is going to be a lateral thoracic vein. There will be no collection that you can see here, right? So it is Mondor's disease. Recurrent cyst formation is an isolated component. Bloody nipple discharge. Bloody nipple discharge, the most common cause. It is going to be duct papilloma. It is going to be duct papilloma. It is not a factor of Zuska's disease. Otherwise, it can also be seen in ductal carcinoma. It is called as the ductal carcinoma, or it can also be seen in ec. It can also be seen in duct ectasia. Okay. तो यही direct after P. I am not able to get your question, Tanmay. Sir, I found out regarding yesterday. Okay, got it. So answer here, it is going to be recurrent retroareolar abscess. Okay. Duct ectasia will have, see, duct ectasia can also be associated with greenish nipple discharge. So duct ectasia can have greenish nipple discharge. They can also have black or brownish nipple discharge, called as the black or brownish discharge. And the last one that you have, This is going to be, it can also be associated bloody discharge. It can also be associated bloody nipple discharge. Okay. So this is with respect to Zuskas. Clear? So going to the next question. This one. Now, I have a patient presented with an eczematous ulcerated lesion involving the nipple and areola. What is the next step in the diagnosis? So, diagnosis here, if there is unilateral eczema involving the nipple areola complex, this is what we call it as the Paget's disease of the breast. It's the Paget's disease of the breast. Now, Paget's disease is because of an underlying malignancy and it is associated with duct invasive ductal carcinoma in subareolar ducts. It is arising from the subareolar ducts. Usually, when we say Paget's disease, the comparison of the Paget's disease is done with respect to eczema of the breast. So, how do you differentiate between a regular eczema that arises in the breast in compare to that of the Paget's disease of the breast? So, eczema in comparison to that of the Paget's disease of the breast. In order to understand, let's compare both the breast. This is nipple area complex, this is the axillary tail of Spencer. Nipple area complex, axillary tail of. Now, eczema, when I say it is going to be involving both the breast, it is usually bilateral. It usually spreads away from the nipple areolar complex. It usually spreads away from the nipple areolar complex. Paget's disease, on the other hand, they involve the nipple areolar complex. They spread towards the nipple areolar complex and eventually they destroy the nipple areolar complex. Okay? Eventually, they destroy the nipple areolar complex. Another very important thing is Paget's is usually unilateral, right? Eczema is usually bilateral. This is unilateral. Here, they have centrifugal. That means they grow away from the nipple and areolar complex. This is centripetal eczema. That means it grows towards the nipple areolar complex. Here, nipple and areola are spread. They are spread, but here the nipple and areola is destroyed. Here, the nipple and the areolar complex is destroyed. This is going to be destroyed. That is in the context of Paget's. Now, when you look at the Paget's, the investigation of choice for Paget's disease is going to be punch biopsy of the nipple areolar complex. Management, it is going to be same as that of any other form of breast cancer. So here the answer, as we have diagnosed, is at Paget's, and they're asking what is the investigation, not an excisional biopsy, not an FNSC, not a core biopsy. This is going to be punch biopsy. That means you are going to take the biopsy from the multiple quadrants. I will divide this entire lesion into 4 quadrants and I'll take multiple samples from each quadrant, and this is what we call it as the punch biopsy, right? Multiple sites for biopsies are taken. Right. Moving on to the next question. Now, this is a straightforward question. Most of you will be able to answer it. I have a young female, 21-year-old female. There is going to be small, smooth, freely mobile lump within the breast tissue. There's a family history of breast cancer. Okay, what is the most likely diagnosis? Even if there's a family history of breast cancer, it does not rule out a young female with a hypermobile mass or a hypermobile lump goes in favor of fibroadenoma of the breast. It is going to be fibroadenoma of the breast. Fibroadenosis is a vague palpable mass or a vague palpable lump. It is not going to have a well-defined border. It is going to be irregular. and this is also going to be nodular, unlike fibroadenoma. And fibroadenosis is also associated with pain. Fibroadenosis is also associated with pain. So answer here is going to be fibroadenoma of the breast. Okay. Now, one thing that they'll ask you with respect to fibroadenoma of the breast that we all should be aware of. Now, fibroadenoma of the breast is also known as breast mouse. Is also known as breast mouse because it is hypermobile. Because it is a hypermobile, right? When you talk about the fibroadenoma of the breast, what is the first investigation in this case? It is going to be ultrasound. It is going to be ultrasound, right? So ultrasound becomes the first investigation in order to conclude that this is the fibroadenoma of the breast. When you do a mammography, in a fibroadenoma, and that too in age above 40 years, that means there is been there for a longer duration of time, you will see here there will be presence of popcorn calcification. There will be popcorn calcification. Here's the thing, when you have a popcorn calcification on a mammography, if there is a popcorn calcification on mammography, then the answer is going to be fibroadenoma of breast. If it is present on a chest x-ray, then it is going to be your pulmonary hamartoma. It is going to be your pulmonary hamartoma, that is a chest x-ray. If it is going to be on the MRI head, it is going to be cavernous hemangioma. This is going to be the cavernous hemangioma. And if it is seen as popcorn cells, presence of popcorn cells, then it will be in your lymphocyte predominant. It is lymphocyte predominant, Hodgkin's. It is a lymphocyte predominant Hodgkin's lymphoma. Diagnosis will be obviously with FNSC. Management when it comes down, remember fibroadenoma size less than 5 centimeters. It is going to be observation and follow-up, or simple observation. Size more than 5 centimeters, it has to be done as enucleation. Size greater than 5 centimeters, it is going to be enucleation, right? So here it is going to be the fibroadenoma of the breast. It is your fibroadenoma of the. Now, another question that you have, again, repeatedly asked question, luminal B for the breast cancer subtype is characterized by which receptor profile? Is characterized by which? Fibroadenosis ke liye, it is not surgery, it's a medical management. We give evening primrose oil, which is a topical oil. You can ask the patient to apply it to reduce the pain. Now, when you talk about the receptor status in the breast cancer, so we'll be looking on the estrogen receptor status, the progesterone receptor status, and the HER2 neogene status. Now, we have the luminal A, you have the luminal B, right? So, again, just to avoid confusion, there are various components of it. You have the luminal A criteria, you have the luminal B criteria, you have the basal cell type and the HER2 neotype or the enriched variety. Now, I don't want you to get confused. I know there'll be a lot of burdening information on the receptor status. Could you tell me any other components that can be involved or included in the receptor status? Anything else that can be included? So estrogen, progesterone, HER2 neo, everybody knows it. Apart from that, anything else that you have? A proliferative index that I can consider is going to be Ki67, which is going to be absolutely correct, hot chocolate. It is going to be Ki67. So you have luminal A, you have luminal B, then you have the basal cell type. The basal cell type. And then you have HER2 neotype or HER2 enriched. You have HER2 enriched. Another new addition that you have is going to be the Claudin low. The Claudin low variety, right? Now, in a luminal A, estrogen is positive, progesterone is positive, HER2 neogene is negative, and Ki67 index is low. In luminal B, all three of them are going to be positive. Hence, it is called as triple positive breast cancer. And in luminal B, sorry, I've written ulta. Yeah, 1 second, guys, 1 second. Some glitch here. Just give me a second. Okay. So look at the proliferative indexes, that is the Ki67. The proliferative index of Ki67 here is going to be slightly higher up. But I'm just, yeah, we are talking about the components only. So just don't jump the gun. I will tell you exactly where to be put across. Okay. Okay. In basal cell type, you will see all these components are going to be negative. Here the Ki67 is high. In basal, it is going to be high again. Into HER2 neogene, it is only HER2 neogene which is positive, and the Ki67 proliferate index is high. In Claudin low, you will see the receptor status is going to be negative. That is the ERPR is going to be negative. HER2 neogene is also negative. Claudin is going to be low, and it is called as the Claudin low component. It is called as the Claudin low component. Okay. Now, when you look at the entire component, remember the best prognosis. The best prognosis is going to be A, and the worst prognosis is going to be triple negative, which is the basal cell type. It is worst. B, because all of them are positive, B is also called as triple positive. It is a triple positive breast cancer. Basal cell type is called as triple negative. It is called as the triple. Okay. Now, they're saying luminal B, it is going to be all three are going to be positive, and that is going to be answer here is also going to be A for Ahmedabad, right? It is a triple positive breast cancer. Now, the only thing that will ask you is if the HER2 neogene is positive. If the HER2 neogene is positive, what drug are we going to use? The drug of choice is going to be your trastuzumab. And this trastuzumab is also called as Herceptin. It is your Herceptin. It is your Herceptin. Okay? So that is your luminal B criteria. Now, a very, very important question. This I am anticipating for you to ask in your upcoming NEET PG exam or a NEET SS exam. A very, very repeatedly asked question. Uh, I mean, in our usual ward rounds, if you're attending your surgery clinics, if you attend your breast clinics, this is something that I'll always be very interested in knowing if an intern or a resident knows this or not. That is a pathological complete response. We call it as the PCR. Following a neoadjuvant chemotherapy is most commonly seen in which subtype of breast cancer? Now, this is a beautiful question. ठीक है, तो पहले तो ये समझ लेते हैं कि what is the objective. Now, we start the patient on something called as a neoadjuvant chemotherapy, that is chemotherapy prior to the surgery. I will give the first cycle. After giving the first cycle, I'll take the patient for the second cycle. After giving the second cycle, I will wait for the period of third cycle, that is 21. So after 21 days, I would do something called as response assessment. I will do something called as the response assessment. This itself is your exam question. That means when do you want to do a response assessment in a patient who's receiving neoadjuvant chemotherapy? I will do 21 days after completing 2 cycles. Right? I'm repeating again. I will do a response assessment after completing 21 days after completing 2 cycles of chemotherapy. Again, 2 cycles, I'll wait for 21 days and then I will go with response assessment. Now, this response assessment is also commonly referred to as or known as the receipt. It is also called as the receipt. Now, what do you mean by this? It is called as a response evaluation. This is defined as response evaluation criteria in solid tumor. In solid, this is what we call it as the RECIST. Okay. Before the 3rd cycle, absolutely correct, hot chocolate, or after complete, because the day. Okay, another interesting thing is time period between 2 cycles is 21 days. Time period between 2 cycles are going to be 21 days. So I finished 1st cycle, wait for 21 days, give 2nd cycle, wait for another 21 days. I should have given the 3rd cycle, but before giving the 3rd cycle, I will go for response assessment. I'll go with response assessment. Now, what are the responses that we have? Now, the responses that we have something called as CR, that means complete response. CR stands for complete response. That is, lesion is non-detectable clinically or on imaging. We have lesion not detectable, lesion not detectable on clinical examination, on clinical examination and image. That is on ultrasound also. You're not able to find. That means a complete response is there. Then there's something called as PR. PR stands for partial response. PR stands for partial response. Now, in a partial response, we can say more than or equal to 30% reduction. 30% reduction in maximum diameter. So whichever orientation maximum diameter is there, there's a 30% response or 30% decreases. That's called as partial response. SD is what we call it as the stable disease. Now, in a stable disease, the reduction is less than 30%. If there's less than 30% of reduction in maximum diameter, we call it as the stable disease. Then we call it as PD, which is called as the progressive disease, which is called as a progressive disease. Progressive disease, if there is more than or equal to 20% increase in maximum diameter, increase in maximum diameter after giving the therapy. Okay. So now we have a clear understanding. What do you mean by a complete response? What do you mean by partial response? What is a stable disease? And what is a progressive disease? Now the question is pathological complete response. That means after giving a neoadjuvant chemotherapy, it is going to be non-detectable clinically as well as imaging. Following a neoadjuvant chemotherapy is most commonly seen in which subtype of breast cancer? Now, please do not get confused by this, right? Because when you look at this, luminal A has the overall best prognosis. Luminal A overall has the best prognosis. When you look at the luminal B is going to be triple positive. It is triple positive. HER2 enriched is usually having poor prognosis. It is poor prognosis. Triple negative is worse prognosis. Okay. These are the words we usually describe to put across here. Now the question is not this. Question is, which of the following subtypes respond better? So we say pathological complete response following a neoadjuvant therapy is most commonly seen in which subtype of breast cancer? The seen in which subtype of breast cancer? Quick feedback. Now this is a question. This is a question that I'm really keen on. Quick feedback. Waiting for the response, guys. Which one, guys? Okay. So here, as you can see, triple negative I have given as the worst prognosis because there's no drug available. But it has been found that they are the one. See, in terms of when I say worst prognosis, because of the recurrence. But initially, when you see a pathological response, it is also seen, I can say the best response to the neoadjuvant chemotherapy is also seen in triple negative disease. Okay? So it is also seen in triple negative. So triple negative is associated with best response. It is having the best response to neoadjuvant chemotherapy. Okay? Here we think the answer could have been either luminal A or luminal B, but remember the one that responds best. Now this is a line that is picked up from Sebastian. It's a tricky component. We don't know the exact patho component behind it or the exact nature of why it is happening, but it has been seen. The best response is seen with triple negative breast cancer. Okay? So, now, genetic testing is not indicated in which scenario? This is a straight question. This is a straight question from Bailey and Love. Okay? Now, when you look at in which condition it has been considered, so I've just given you a list here so that it becomes easier for us to assess. Number one, the first thing is an individual of an age with an unknown pathogenesis variant of cancer susceptible gene in family. So basically, it's the familial component of breast cancer diagnosed below the age of 50 years. That is triple negative breast cancer. TNBC stands for triple negative breast cancer below the age of 60 years. Two breast cancers which are present as different primaries. If a breast cancer at any age with one or more relative with breast cancer diagnosed before the age of 50 years, breast cancer at any age with two or more affected relatives, male breast cancer, an individual or a family history of three or more of the following, right? That is breast cancer is there, sarcomas, adrenocortical carcinomas, brain tumors, leukemia, colon cancers, endometrial cancer, thyroid cancers. I've given you the objective. If it is a lobular breast cancer or diffuse gastric cancer in combination, breast cancer with your GI malignancies, I've given you the other components which are important. But the carry home message that you need to understand that a breast cancer diagnosed before the age of 50 years, or if there is a triple negative breast cancer below the age of or before the age of 60 years. Okay, the two very important points. Now it says genetic testing for breast cancer not indicated in the option number one that we have a triple negative breast cancer diagnosed before the age of 60. As you can see, it is straight up from the table. This is an indication. Two primary tumors in both the breast. Now when I say it is not both the breast, it is in one individual breast. Male breast cancer, yes. Breast cancer diagnosed before the age of 50 years is correct. You can see here when I say two breast cancer primaries, that is on the same breast. Two breast cancer primaries, which is on the same breast. Okay. Then you have the male breast cancer, which is also here. This also needs a. So breast cancer diagnosed below the age of 50 years, male breast cancer and triple negative breast cancer diagnosed before the age of 60 years. All these require genetic testing. The two primary tumors in both breasts, it has to be in one single breast that warrants for it. So answer here is going to be B for Bombay. Is going to be B for Bombay. So indication for genetic risk evaluation. There's a table that we've taken straight up from your Bailey. So just revise it once. Okay. So that's all that we have for today in our BLS Pro. So this is how you will be asked your MCQs in the exam, and this is how you need to prepare it. Okay. So I try to cover a slight tricky questions that is usually asked. There's a lot of other questions also. I have another session on the breast only. So we have completed one, and then it's going to be another one. But a synchronous and metachronous is about the time at which you are going to look at the lesion. If you have two different primaries that are diagnosed at the same time, they got a synchronous. And if you diagnose one lesion today and another lesion after 6 months, it is called as metachronous. It is not about the position. Okay. Another question that you can ask is your, multifocal, multicentric disease. Okay. When it's a multifocal, multiple foci of lesion in one single quadrant. If there are two different lesions, two different quadrants, they're called as multicentric disease. How triple negative best response, I don't know. But yes, the one which is associated with best response to a neoadjuvant chemotherapy is seen in a triple negative disease. Luminal A has best prognosis because if the receptor status is positive, you can give hormonal therapy. HER2-neo is actually a aggressive marker. So if the HER2-neo is positive, the tumors are considered to be more aggressive. Negative is less aggressive. Yeah. So that is it for today. Thank you so much for joining. We'll try to bring more questions. I'll try to increase the level of questions also, and then we'll discuss in more elaborate fashion for the same as well. Until then, thank you so much. Take care. Goodbye. Somebody's asking questions of pathophysiology, third space loss and perforation obstruction. But see, yeah, next class you come and revise. Somebody's asking, so why there is perforation and third space loss in an obstruction? So what happens in a bowel obstruction is, if you look at the entire context of bowel obstruction, you take this as the representation of the bowel wall. Okay? This is the bowel wall. Now just imagine that there is an obstruction that is present here and this is like occluding here. Okay? Now what is going to happen? The content is going to come, it is going to get loaded here, it is now going to get occluded. Now as it is getting occluded, what will happen to the pressure inside the lumen? It will increase. If the pressure inside the lumen will increase, what is going to happen? Because the bowel wall is going to get compressed, the pressure on the bowel wall will increase. Now this increase in pressure in the bowel wall will result in congestion in the veins. So the veins will not be able to empty, so it will result in congestion of the bowel wall. Now that congestion will result in increase in pressure in the bowel wall further, and that increase will cause occlusion of the arteries, and the blood supply to that part of the bowel will get diminished, hence resulting hypoxia. Hypoxia will result in inflammation. Inflammation will cause edema. Edema will cause third space loss. Now that ischemia that is settling in will result in necrosis, and that necrosis will result in perforation. So ultimately it goes into perforatory state. Okay. So this is how the third space loss, that is edema, occurs, and then the perforation takes. Clear? Got it? So congestion, diminished blood supply, hypoxia, inflammation, perforation. Sorted. So, thank you so much, guys. Take care. Good night. Bye bye. Take care.